Dr.T.SUDHA, Associate Professor, Department of Pharmaceutical Chemistry and Analysis, Wales Institute of Science and Technology and Advanced Studies. Today's topic is scrub TYPHUS. It contains etiology, vector biology, pathogenesis, clinical manifestation, diagnostic workup, and evidence-based management. The disease scrub typhus, an acute zoonotic rickettsial illness caused by Orencia thusmanisch, presenting as acute undifferentiated fever and characteristically marked by an inoculation azure. That is a geographical endemicity. It is covering over 13 million kilometers square for northern Japan and eastern Russia, south to northern Australia, and west to Pakistan and Afghanistan. Over 1 million people live at risk, with approximately 1 million clinical cases occurring annually, making it a leading cause of acute non-malarial viral illness in Southeast Asia. What is the transmission and the seasonality of this disease? Transmission occurs preliminary in mid-island focal microhabitats with scrub vegetation, overgrown cleanliness, and riverbanks harboring mite colonies. Year-round transmission occurs in tropical zones, whereas temperate zones exhibit distinct seasonal peaks during rainy seasons or late autumn when larval mites hatch. Then the disease etiology and microbiology. It is caused by an Oriental Thusmani, a gram-negative obligate intracellular bacterium within the family Rickettsaceae. Unlike standard gram-negative bacteria, Orencia thusmanisch lacks peptidoglycan and lipopolysaccharide in its cell wall, conferring intrinsic resistance to beta-lactam antibiotics. It expresses a major 56 kDa strain-specific surface protein antigen with a substantial antigenic variability. Vector biology and transmission, like it is classified into four categories. One is primary vector. It is transmitted by larval mites, predominantly species of, that is, L. dinleis. Second one, only the larval stage. It feeds on mammalian lymph and tissue fluids, and adult mites are free living soil peridates. Third one, it is maintained via transviral and transdial transmission within the mite population occurs generation. Fourth one, humans become accidentally infected when entering infected scrub vegetation and stepping into active mite hotspots. Next, pathogenesis and disease mechanism. It is three category. Number one, inoculation and local replication. Number two, dissemination and vasculitis. Number three, endothelial dysfunction. Next one, clinical presentation and initial onset. That is incubation period. The range of 6 to 21 days post Chiger bite. Second one, arboret febrile onset. That is high grade continuous or remitted fever. That is fever degree is 104 degree Fahrenheit or 40 degrees Celsius, accompanied by shaking, chills, and rigors. Next, continuational symptoms: severe incapacitating retroorbital headache, generalized instance myalgia, anexia, and myalgia. Next one, ocular and upper respiratory findings, It is produced by photophobia, dry cough, and mild tachypnea in the early stages. Pathognomic cutaneous eschar. It is focused to the first one focus to the morphology and evaluation. It begins a painless papule at the bite site, rapidly ulcerates and form a characteristic black necrotic crust surrounded by an 3 to 10 millimeter diameter. Next one, diagnostic hallmark. It is present in 30% to 80% of confirmed cases depending on strain virulence and host immunity. It is virtually pathogenic for scrub typhus in epidemic regions. Next, anatomical distribution. Most commonly discovered in warm, moist flexural body fluid regions, for example, umbilicals and bells, inflammatory folds and neck. Physical examination findings, that is a 35% centrifugal mucopolar rash. Systemic clinical signs, that is number 1, mucopolar exanthem, generalized lymphadenopathy, then systemic complications and MODS, pulmonary and renal, central nervous system, cardiovascular and blood. Laboratory parameters and frequency, hepatic transmutations, thrombocytopenia, hypoalbuminemia, leukocytes or leukopenia. Hepatic transmutations 85%, thrombocytopenia 75%, hypoalbuminemia 60%, leukopenia 50%. This is a laboratory parameters and frequency. Next, diagnostic workup and confirmation. Gold standard serology, IgM, ELISA and RDTS test. Molecular diagnostic, for example PCR test. Then Weil flexi test, that is called a historical ejaculation test. It is low sensitivity and specificity, no longer recommended on sole diagnostic. Then ELISA test and RDTS, that is a highly sensitive diagnostic tool in acute phase, that is after 7 days, widely used in clinical settings. Gold standard under serology, it is indirect immunofluorescence assay, that is IFA. It's showing there is a 4-fold rise in paired IgM or IgG antibody. Then molecular diagnostic, that is PCR, nested PCR targeting 56 KDA, TSA gene or whole blood or Acer swab specimens, that is highest early yield. Next one, differential diagnosis matrix, that is 4 types. Disease entry, etiology, distinguishing features, diagnostic test, that is disease entity. First one, scrub types, that is O trisomania, that is Acer, regional lymphadenopathy, scrub exposure. That is what is the test here? Diagnostic test, IgM, ELISA or Acer PCR. Next one, dengue fever, dengue virus test, retino-orbital pain, severe bone pain, plasma leakage. Diagnostic test is NSI antigen or ELISA test. Next, malaria, Plasmodium SPP, that is high chills, fever, then predominant, it causes peripheral smear or RDT test. Next, leptospirosis, leptospiria intragans, it is a conjunctival suspension, severe cough, muscle transverse, IgM, ELISA or MAT. Next one, typhoid fever, salmonella typhi, steep leader fever, relative bradycardia, rose spots, blood cultural or vital. Then pharmacological management, That is first line antimicrobial therapy, doxycycline 100 mg, that is twice daily for 7 days, or IV 100 mg IV. Next, rapid response difference usually occurs within 24 hours to 48 hours of initiation. Lack of response suggestion an alternative diagnosis or resistant strain. Empirical treatment should be initiated immediately upon clinical suspension without waiting for lab confirmations. Alternative and special populations, in the case of doxycycline, in any allergic if it should be produced, or penicillin if you take an allergy should be produced, you go for a azithromycin 500 mg PO daily for 3 to 5 days. Preferred first line drug in pregnant women and pediatric population. Doxycycline resistant, sometimes it should be resistant, go for a azithromycin or rifampicin 600 to 900 mg per day, indicated in areas with unknown doxycycline resistant strains, for example northern Thailand. Then prevention and prognosis. Prognosis is excellent with prompt antibiotic therapy. That mortality is less than 1%, and untreated case carry up to 30% mortality. Thank you for watching.